degeneration due to your age. Now, first of all, what is your macula? If you think of the film of a camera or the back of your eye, light rays travels through your cornea, through your lens, and it gets bent down to one point of focus. And that very point of focus, that is your macula. That's basically the most important part of your eye. What happens as we get older, and it's more prevalent in Caucasians, there's two types: wet age-related macular degeneration or dry age-related macular degeneration. If doctor detects, when he looks at the back of your eye, and it looks almost as if a piece of metal that's flat got beaten like this, and that's what we refer to as drusen. It's like dry drusen spots in the macular area. That might affect your vision in terms of quality. When you look at a straight line, you can see slight distortions. There's nothing really one can do for dry macular degeneration, but there's also a very good chance that it will just stay like that. It won't get worse. It's not so bad to have it, so to speak. The other age-related macular degeneration is what we refer to as wet. Now, that is when fluid accumulates in that macular area. The reason why it's happening is age. And as we get older. The fluid will distort your vision. Again, when you look at straight lines, it will be bent. When you look at your distance vision objects, even close up, with your best corrected glasses, you'll tell your optometrist that it's just not good enough, it's not the way I used to see. Now, the OCT scan that we do to just clinically see how many fluid and how much fluid and where the fluid is located. So it's a scan that measures the back of your eye, which is your retina. Your retina's got 10 layers, and it will give us a cross-section of your retina. So we can clearly see there will be lumps and bumps filled with pockets of fluid at the back of the eye, and we can clearly see it. You yourself will be able to look at it and see, yes, I can see there's the problem. We need to get rid of the fluid in the back of the eye. And the way to treat it is by putting a medication into the eye that's going to absorb the fluid, in order for you to have your retina flatter again, so that light rays can come down to one point of focus, which is your macula. Now, Avastin is a type of medication that we put into the eye in order for the fluid to be absorbed. Now, we can't guarantee that Avastin works effectively on every person, and some people need more, or some patients need more series of Avastin than others. When I talk about a series, how Avastin works is we do 3 sets of Avastin, or 3 what we call injections, 1 month apart, and then we scan you again to see whether the swelling at the back of the eye is less. What will happen, or how will you prepare yourself for this type of procedure that's called Avastin? We have certain Avastin days. It's not an in-hospital procedure. It's not something that you're going to go to theatre for. Doctor's got a dental chair where he performs it in a small surgical facility in our rooms. So on the day that's an Avastin day, we'll prepare your eye. We don't want any bugs to get in there. Remember, it's something that we put into the eye. So if something else gets into the eye, it can cause sight-threatening infections that requires a whole different procedure. On the day of the procedure, doctor will dilute betadine, and we'll put quite a few drops. Almost half an hour you'll sit here and you'll think nothing is really happening. Why are they putting all these drops into my eyes? It's to just get that area to be as clean as possible. Also, what you need to know, it is not a painful procedure. Thinking of an injection in the eye is a horrible thought, but doctor anesthetizes the area that is going to inject in completely. So you will lie on a flat bed, you'll have a small surgical cap on, because we just want to have everything that can potentially cause an infection away. Doctor is scrubbed completely as if he's going to do a surgical procedure in theatre. We use again a small speculum to keep the eye open, so you don't have to worry about keeping the eye open. We'll ask you to look towards your nose, because the procedure, doctor will, if you think of your eye in terms of a clock, the injection usually takes place at around 2 o'clock. Doctor then prepares everything that he needs to. The whole procedure takes about 5 to 10 minutes. The preparation and the disinfection, and that takes longer than the actual small procedure. What you will see as he's doing it, you'll see almost this fluid floating around, and that's the medication going into the eye. For maybe the next 2 or 3 days you'll be a little bit scratchy. That is because of doctor's anesthetic. We give you lubricant drops to take home, so as you need it, you just put it in. You can do 5-6 times a day, or if you don't need it, you don't have to put it in. You'll have a mild discomfort when you go home. We ask patients again, go and sleep for 2 to 3 hours just for that tear film to be completely stable. Don't expect your vision to improve in the next few days or weeks. We need to wait a month, do it again, another month, do it again, third month, do it again, and then after another month we scan you. Now you can progressively maybe start to see an improvement, and we want you to be critical. We want you to look at one thing maybe in your house on day 1, and then a month later you just look at it again and you see, am I seeing it the same? Am I seeing it maybe slightly better? Because we'll ask you subjectively when you come for your scan after 4 months, do you notice an improvement in your vision? And if the scan indicates that the swelling is gone or the swelling is less, then we will either continue with another series of Avastin, or we will ask you maybe wait. If we see that it really looks well, wait another 2 to 3 months. We repeat the scan and just make sure, because you don't want to treat it, get it back to normal, and then just leave it. You want to, if the treatment needs to be going on for a bit longer, we want to make sure that we don't let you go and then it flares up again, and then it's like a forest fire, and we have no control of it. What I can also say is Avastin, if they see that you are really almost resistant to Avastin, there's another medication called Lucentis that we can put into the eye. Now Lucentis is why worldwide the first line of medication will be Avastin. The reason being is that Avastin is much less expensive than the Lucentis, and medical aids are quite, they'd want you to go the Avastin route first, yes, with motivation and scans being done. If we can prove that the Avastin is not working, we can go over onto Lucentis. And the third option in terms of intraocular medication is something called Ozurdex. It's a small, almost like a pellet that doctor will, through the same small, it's not as if he needs to use a bigger insertion place. It's almost like a small, slow release tablet. So he puts the medication in, and it slowly releases the medication, and it almost works for longer. So there's different types of options on how to treat age-related macular degeneration in the case of when it is wet. What other reasons would you need to use Avastin for? If you're diabetic, or maybe non-diabetic or not diagnosed diabetic yet, what can happen is you can have a bleed at the back of the eye. Now you won't have the same symptoms as with macular degeneration where you see a distorted line. You'll see almost, it depends on how big the bleed is, but you'll see almost like a area in front of you, which we call a scotoma, and it's like a black area, so you can't really see it. It was like a really blurred area because you are looking through blood. And what we then do is to also use the Avastin to absorb the blood. It can take longer, maybe 3, maybe 6 injections, in order for us to absorb the blood fully. So those are the 2 main reasons when one would use the Avastin or intravitreal injection.